This is an audio review of Chapter 19 for Introduction to Sociology, Introduction to Health and Medicine. So, to understand health from a sociological perspective, we're always looking at the social construction of health. So the ways in which our culture impacts how we understand, how we interpret, and how we treat health conditions. So medical sociology is the systematic study of how humans manage issues of health and illness, disease and disorders, and healthcare for both sick and healthy. Medical sociologists study the physical, mental, and social components of health and illness. Issues that medical sociologists study focus on the doctor-patient relationship, the structure and socioeconomics of healthcare, and how culture impacts attitudes towards disease and wellness. So the social construction of health is another major research topic within medical sociology. The idea of the social construction of health emphasizes that socio-cultural aspects of the discipline's approach to physical, objectively definable phenomenon, meaning like diseases are just a thing that exist, but how we look at them and how we interpret them and how we decide whether they're serious or not has to do with our culture and the meanings within it. So sociologists Conrad and Barker break this concept down into three subheadings: the cultural meanings of illness, the social construction of illness experience, and the social construction of medical knowledge, all of which we're going to cover right now. So cultural meaning of illness, that's the first one. Many medical sociologists argue that illnesses have both a biological and experiential component, and that these components exist independently of each other. Our culture, not our biology, dictates what illnesses are stigmatized and which aren't, which are considered disabilities and which are not, and which are deemed contestable, meaning some medical professionals will say that disease doesn't even exist, as opposed to definitive illnesses that are recognized as like they are an illness. So Goffman is really helpful to understanding the stigmatization of some illnesses. Irving Goffman described how social stigmas obstruct individuals from fully integrating into society. So Goffman suggests that we can view illness as a stigma that can drive others to view the ill in a desirable manner. The stigmatization of illness has the greatest effect on the patient and the kind of care they receive. Our society and our healthcare institutions discriminate against certain diseases like mental disorders, AIDS, venereal diseases, skin disorders, things like this. And so facilities for these diseases may be subpar, they may be segregated from other healthcare areas, or relegated to poorer environments. So the stigma also keeps people from, seeking help for their illness. So that makes the illness worse than it needs to be because they don't want to face stigma for having those particular illnesses. There's a video in your additional resources that further explores this. And then contested illnesses are those that are questioned or questionable by some medical professionals. So things like chronic fatigue syndrome or fibromyalgia. Some people think it's a real disease, others think that it's just in the patient's heads. And so it really depends on the opinion of the medical professional. And this can, of course, affect how patients receive care. Because if you show up and you're like, I'm having all these pains, and your doctor's like, that's not real, then they're probably not going to help you very much. Okay, so then looking at the illness experience, the idea of the social construction of the illness experience is based on the concept of reality as a social construction, meaning there's no objective reality, there's only our perceptions of it. So the social construction of illness deals with issues of like how some patients, they really want to control the manner in which they reveal their disease, or, how they then cope with the changes in their lives based on diseases that they are experiencing. In terms of constructing the illness experience, culture and individual personality both play a significant role. For some people, a long-term illness can have the effect of making the world smaller, meaning their illness becomes their world. But for others, their illness can be a chance for discovery or reimagining a new self. So, for example, some people losing a limb can be a status loss, while for others it could be motivation. And we see this in folks who compete in the Paralympics. So that's also in your additional resources, a little video about that. So culture plays a huge role in how an individual experiences illness. Widespread diseases like AIDS or breast cancer have specific cultural markers that have changed over the years, and that affects how individuals and how society itself views those diseases. So moving on to the social construction of medical knowledge. Medical knowledge is also constructed. It can both reflect and reproduce inequalities in gender, social class, race, ethnicity, and other factors. So Conrad and Barker use examples of social construction of women's health and how medical knowledge has changed significantly in the course of a few generations. For instance, in the early 19th century, pregnant women were discouraged from driving or dancing for fear that it would harm their unborn child, much as they are discouraged today for a more valid reason from smoking or drinking, right? But even this whole characterization of women's health as a disability, when it comes to being pregnant, things like that, part of the reason we don't really understand these things as well as we should is because we consider men to be the default and women to be something else, right? Something compared to the default. So as a result, we really haven't invested as much medical knowledge into understanding women's bodies or reproductive systems. So this even goes to the fact that for many years, Congress had to pass a law in the 1990s to make it so that pills that were being tested would also be tested on women, because for many years, the same medications that would be given to men, they were assumed, well, they work the same for women, when sometimes they don't, right? Or, even crash test dummies were only male for many years. So things like that affect how we can even understand medical knowledge based on those biases that we have. All right, so moving on to global health, social epidemiology is a study of the causes and distribution of diseases. So this looks at how social problems are connected to health problems that occur in different areas of the world or in different populations of people. So these epidemiological studies show how the health problems of high-income nations are really different from those in low-income nations. So some diseases like cancer happen everywhere, but others like obesity, heart disease, respiratory disease, and diabetes are much more common in high-income countries as a direct result of a sedentary lifestyle combined with a poor diet. High-income nations have a higher incidence of depression, right? But in contrast, low-income nations will have much more malaria and tuberculosis. So that really shows that, the status of global health is connected to wealth and how wealth can then shape the access that someone has to healthcare and what kind of medications or services can be provided. And then when you look at the health in high-income nations, obesity, which is on the rise in high-income nations, has been linked to a lot of diseases, including cardiovascular problems, musculoskeletal problems, respiratory issues. But of course, when you look at this as the world, obesity rates are rising in a lot of countries that are high income. The United States has the highest obesity rate. So researchers wanted to understand why these rates were rising, and they came up with a couple ideas. About 5 of them specifically that they cover in the book. So the first is that improvements in technology and reduced family size have led to a reduction of work that's done in the household. Also, the second one is unhealthy market goods like processed foods and artificial sweeteners replace, kind of home-cooked things that are healthier or more naturally derived. Leisure activities are growing more sedentary, meaning instead of riding a bike, you're sitting on ass playing a video game, kind of things like that. 4, more workers are shifting from active work like manufacturing or agriculture to service industries where at your job you're either sitting in a cubicle or maybe just kind of standing in one spot for a while helping customers, but you're not, getting that physical manual labor that people used to get and also do get in less developed countries. And the last one is increased access to passive transportation has led to more driving and less walking. So obesity and weight issues have significant societal costs, including lower life expectancies and higher shared healthcare costs. High-income countries also have higher rates of depression, like I mentioned before. So somewhat recent research looked at how the likelihood of having depression in high-income countries is about 10 times as much as in lower-income countries. So the researchers speculate that the higher rate of depression can be linked to greater income inequality that exists in high-income nations, right? You have a better overall lifestyle, but in relative poverty versus absolute poverty, people are struggling. And then when looking at low-income nations, low-income countries struggle to manage problems of infectious disease, high infant mortality rates, scarce medical personnel, and inadequate water and sewer systems. These are issues which high-income countries rarely even think about or take for granted because those resources are provided for the government. But in low-income nations, these are central health issues, such as having a sewer system, having clean water that's not filled with diseases. We take that for granted in high-income countries. One of the biggest contributors to medical issues in low-income countries is that access to clean water and basic sanitation. According to a 2014 UNICEF report, Almost half of the developing world's population lacks improved sanitation facilities. The World Health Organization tracks health-related data for 193 countries, and they found the following statistics that are also in your book, that globally the rate of mortality for children under 5 was 60 per 1,000 live births. In low-income countries, that's about 117 per low-income or per live birth. So basically double. There's double the infant rate or the infant mortality rate in low-income countries. Also, most frequent causes of death for children under 5 were pneumonia and diarrheal diseases. So these are often coming from, again, access to clean water and not having access to available medical care. And the availability of doctors and nurses in low-income countries is 1/10 that of nations with high incomes. So this means, challenges in access to medical education affects how many people are then trained professionals, and the lack of the institutional structures for the medical system means a lack of doctors as well. This is why you have non-governmental organizations like Doctors Without Borders that'll go into some of these low-income countries to provide help. But it's really not enough unless there's like a larger shift within the institutions of these countries. All right, moving back to the US, when we look at social epidemiology in the US, it's hard to miss that there's inequalities based on race and ethnicity. Being a racial minority means having a shorter average lifespan than whites, and is most notable when we look at infant mortality, which again is the number of deaths given in a time or place per 1,000 of the population. So the rate of infant mortality for Black Americans was nearly twice that of whites, according to research from 2011. So there are even differences when it comes to diseases. Many racial and ethnic minority groups face higher rates of disease, from cancer to heart disease to diabetes, and of course that just means higher death rates as well. And we can see the differences in how people are treated, whether they receive quality care and respect, and the kinds of treatments that they receive. For instance, many communities of color, such as African Americans and Latinx people, are not given pain medications when they're hurting. Some of this is due to social stereotypes, right? That people are deviant, or even kind of going back to stereotypes that came out of slavery to justify slavery, that somehow African Americans were just hardier or less susceptible to pain. And of course, racial and ethnic minorities also receive more crude treatments. They're much more likely to have a limb amputated because of doctor bias that assumes that ethnic minorities aren't going to take care of themselves post-op as well as white patients would. And this has been further complicated by the disparities we've seen in COVID deaths in the US, so I added a video about that to your additional resources to further explore that more recent issue. Okay, so then health by socioeconomic status. It says healthy, but it should say health. Discussions of health by race and ethnicity often overlap with those with socioeconomic status, since the two concepts are intertwined in the US. So morbidity is just the incidence of disease. One of the most significant predictors of a person's morbidity is their social class, so how much money they have. And as we'll talk about later in this lecture, this is due to how we organize our medical system. It does not have to be this way. It does not have to be based on how much money you have, to which kind of care you receive. People can even be turned away or denied care because they don't have enough medical insurance, or they don't have coverage for that particular procedure, or it's an out-of-network hospital. It's a very difficult system to navigate. Also, people who get healthcare from their jobs are people who have good jobs in that dual labor market we talked about before. And few people have access to that, especially if they're poor, because they'll lack the money to pay for college, and you need college degrees for most well-paying jobs. Also, if you're poor, even if you do go to college, you don't have social capital, which then keeps you from getting better jobs and opportunities that move you into a higher social class. So social class and education are related. Level of education is related to health outcomes. People who are more educated tend to do less things that harm their health because they have the financial privilege to do so. So buying the organic food, buying the $6 vegan cheese, you can't do this if you have very little money. What you end up buying is cheap or fast food, or food that's really bad for you because, that's why it's cheap. Food deserts are another concept that's related to this. So another part of, something they mentioned in that video clip as well that I put in your additional resources that talks about when you live in a neighborhood that doesn't have access to a grocery store, but it might have many liquor stores or like 7-Elevens. So this leaves you with very few healthy food options, which means most people end up turning to fast food choices. And then looking at health by gender, women are affected adversely by unequal access to and institutionalized sexism within the healthcare industry. According to a report from the Kaiser Family Foundation, women experienced a decline in their ability to see a specialist between 2001 and 2008. And this report really looks at the explanatory value of intersectional theory. So feminist sociologist Patricia Hill Collins developed this theory which suggests that we can't separate the effects of race, class, gender, sexual orientation, and other attributes when we're looking at the whole of a person's experience, whether it be in the healthcare system or other institutions. So when you look at that research coming from the Kaiser study, they found, for example, that women that were also low income were more likely, 32% compared to 23%, to express concerns about healthcare quality, illustrating the multiple layers of disadvantage by race and sex and gender, right? So the more you complicate the layers at which people experience disadvantages with the healthcare system, we have to understand that some people, like, you can be a poor person that's disabled and also a person of color and also whatever. So when we talk about those barriers to the healthcare system, they can be compounding for certain communities. We can also see an example of institutionalized sexism in the way that women are more likely than men to be diagnosed with certain kinds of mental disorders. Also the fact that, actually it's kind of a fun history of that. There used to be a disease called hysteria, which was just like, it comes from the Latin root for hyster, meaning like, uterus. So basically like hysterical is like crazy womb is kind of like how that would translate. And I'm sure you've heard of that, that woman's being hysterical. They literally thought it was a disease. And the fun fact about that is that, I don't know if any of you know how they treated hysteria. Basically, women would make appointments to go to their doctor, and the doctor would manually stimulate them to orgasm, and then their hysteria would go away. So they basically got so tired of manually stimulating these female clients that they created these machines that basically are the origin of what we now call vibrators. So how did they cure hysteria of vibrators? It's an interesting history. But basically, a lot of those notions came from the idea that women didn't have a sex drive, weren't interested in sex, so therefore it became like a medicalized component instead of part of, a narrative around our sexualities. So anyway, there's that, and then there's also the fact that women are less likely to be taken seriously by doctors. Right? There's thousands of examples of this where doctors didn't take a woman as seriously when she talked about her symptoms, and therefore they spiraled into a situation where she couldn't be saved. Or even the Serena Williams example, right? Serena Williams was pregnant, and she'd previously had a blood clot. And so right after she gave birth, she went out of the room because she didn't want to upset her family by saying this, but she went up to the nurse's station and said, hey, I think I have a blood clot, which can be very dangerous right after giving birth. And she said, I need Lovenox injection, blah, blah, blah. Like, she knew exactly the medication she needed. She knew exactly the symptoms. She was using the lingo, and they ignored her. They just kind of played it off for a while. It took her hours to get the care that she needed. And once they finally did the ultrasound on her, I believe it was her leg or lungs, they found that there was a DVT, a deep vein thrombosis, and, basically she could have had a pulmonary embolism that could have killed her within hours. But they were not taking her seriously. And this is a woman who is one of the most famous women in the world, one of the wealthiest women, right? Has a lot of name recognition. And yet, if she can't get care that's appropriate to, especially like if a man said, hey, I think I have this, here's the exact medication I need, and here's this, the credibility that we then socially lend to men is so much more than we lend to women. And what's kind of, I think, is ironic is that we assume women are more fragile or weak or can't handle pain when they literally like rip open their bodies to push babies out of them. And if you've ever seen any of those period pain simulators, I'm sure you see that stuff going around on like TikTok, social media. They're pretty hilarious because they put this little belt on men and they give them a little taste of what a normal cramp is like, something that women experience pretty much every month. And most men like have a really hard time with it. And you're like, yeah, actually there's research that's also come out that's shown that period cramps can be as bad as a heart attack as far as pain. And that's something that people are experiencing every month and still going to school, going to work, living their lives. And yet our social narratives that say that women aren't strong affects our perception of their strength. So, really we have to think about the concept of medicalization and how it relates to these things. So medicalization refers to the process by which normal aspects of life are considered or deviant and needing medical attention. So many things that are normal for women have been medicalized, like menstruating has become like an issue, PMS, premenstrual syndrome, pregnancy, childbirth, and menopause. And childbirth is really, really medicalized in our country, to the point to where women don't feel confident to do what women have been doing for literally thousands of years. We want to make the natural process more standardized because they want to get you in and get you out, mostly so they can fill that bed again and make more money. And this is particularly a problem in the US because we have a medical system based on capitalism and not a medical system that's, single payer or universal. So in recent decades, there's been an alarming increase in medical interventions and medications, which is leading to the rate of cesarean sections increasing by hundreds of %. So I put a video clip in your additional resources about Pitocin and the ways in which they give women this thing to speed up delivery, but it causes a whole host of other health problems. And how, basically, again, the medical system is trying to basically standardize different bodies. And as we know, sometimes women for the first pregnancy could be in labor for days. Some can be in labor for only a couple hours. We can't standardize these things. You should just be provided the care you need when you need it, right? And not worry about how much it's going to cost and trying to fill that bed so they can charge another person $10,000. Another issue in the US is mental health. People with mental disorders and people with mental illnesses experience a wide range of effects. Anxiety disorders are the most common in the US. All of us feel a little anxious sometimes, but people who have chronic anxiety experiencing it in a very different way, in a very debilitating fashion. So it intervenes with life. Anxiety disorders include feeling worry, fearful, and this would last for months at a time. Anxiety disorders include obsessive compulsive disorder, panic disorders, post-traumatic stress, and other social and specific phobias. Mood disorders are the second most common in the US, with about 10% of adults facing these every year. Mood disorders like depression, bipolar disorder, and others like anxiety. Depression might seem like something that we all experience at some point, and that's true, right? Some of us, you'll feel depressed at some point. But a true depressive episode is it's not the same as feeling sad for a short period of time. It's months. It's a long-term debilitating illness. Like, you can't get out of bed for a month, right? Or you just don't eat for a week because you're just so depressed. Like, that's beyond what most people are experiencing, that sometimes they get confused and think, well, I've felt depressed, so I know what depression is. It's like, no, you don't know what chronic depression is. Bipolar disorder is another one that's characterized by dramatic shifts in energy and mood, often affecting individuals' ability to carry out day-to-day tasks. So they used to call it manic depression because people would swing back and forth from manic and depressive episodes. And depending on which mood disorder you're talking about, that, again, affects a lot of people in this country. But another one is personality disorders, which is about 9% of people in the country. And this is just ways that people act that seem normal to them but seem abnormal to the rest of us. So another very common one in that realm would be attention deficit hyperactivity disorder, or ADHD. Affects 9% of children, 8% of adults on a lifetime basis. ADHD is a very common disorder marked by difficulty paying attention, difficulty controlling behavior, and hyperactivity. So they give a lot of meds and stuff like this to kids to try and do this, but there is some social debate whether the drugs are being overprescribed. In fact, some question whether this disorder is really as widespread as it seems, or if it's just a situation of trying to use meds to force kids to conform to a system of schooling that doesn't account for their attention or their creativity or their energy, right? So maybe it's our education system that's a problem and not the kids. There's also autism spectrum disorders that have gained a lot of attention in recent years. They're basically developmental brain disorders that are characterized by deficits in social interaction, verbal and nonverbal communication, and engagement in repetitive behaviors or interests. So the key feature of serious mental illnesses is that it results in serious functional impairments. But a lot of people are able to, whether it's, anxiety, mood, or personality disorders, are able to function at high functioning levels in society. So disability refers to reduction in one's ability to perform everyday tasks, and there's a lot of different ways to understand this. The term impairment describes physical limitations while reserving the term disability to refer to the social limitations. Before the passage of the Americans with Disabilities Act in 1990, people in the U.S. with disabilities were often excluded from opportunities in social institutions that many of us take for granted. This occurred not only through employment and other forms of discrimination, but also through casual acceptance of most people in the U.S. That, the world should be designed for the convenience of the able-bodied. If you're in a wheelchair and you're trying to use a sidewalk and there's not a wheelchair accessible curb, that's a problem, right? If you are a blind person and you're trying to access information but there's no braille, that's a problem. If you have limited motor control and you're faced with a difficult to grasp door handle, that's a problem. But because privilege affects the way in which people see the world world is built for able-bodied people, and a lot of people that have impairments are basically facing those issues from society because it's not accommodating. So this all comes back to that stigmatization. People with disabilities can be stigmatized by their illness, and this just means that their identity is labeled as different, and it makes it easier to discriminate against people and sometimes even shun them. So from an interactionist point of view, they might point out how your status is being changed, right? That sometimes their status becomes the blind girl or the boy in the wheelchair instead of a full human person with full identity in society. So this can be especially true for those who are disabled due to mental illnesses or disorders as well. Okay, so looking at comparative health and medicine, the U.S. healthcare coverage is broadly divided into two categories: public healthcare and private healthcare. The two main publicly funded healthcare programs are Medicare, which provides health services to people over 65 years old, as well as people who meet other standards or for disability, and Medicaid, which provides services to people with very low incomes who meet other eligibility requirements. And there are other government-funded programs like the Indian Health Service focused on Native Americans, the Veterans Health Administration for veterans, and of course the Children's Health Insurance Program. So I put a video in your additional resources that kind of breaks this down a little bit too. There are, though, the underinsured. That is, people who pay at least 10% of their income on healthcare costs that aren't covered by insurance, or for low-income adults, those whose medical expenses or deductibles are at least 5% of their income. Why are so many people uninsured or underinsured? Skyrocketing healthcare costs are part of the issue. Many people can't afford private health insurance, and their income level is not low enough to meet the eligibility standards for the government-supported insurance. Also, even those who are eligible for Medicaid, the program is less than perfect, right? Not every physician will accept Medicaid payments or patients, so that affects who they can actually go and access resources from. There was this thing called individual mandate that was later struck down in Obamacare, which basically said that you had to have insurance or pay a penalty. And the idea behind it was that if everyone in the pool is paying their money into the health insurance market, then the younger people can help float the older people that have more health consequences, which keeps costs down. But again, they basically, instead, people will not get health insurance until they really, really, really need it. And that drives up the cost of healthcare, and especially before the passage of the Affordable Care Act, or as they call it, Obamacare. Okay, so then looking at healthcare elsewhere. Under socialized medicine, the government owns and runs the system. It employs the doctors, nurses, and other staff, and it owns and runs the hospitals. The best example of socialized medicine is Great Britain, where the NHS, the National Health System, gives free healthcare to all residents. And despite the U.S.'s knee-jerk reaction to any healthcare, or a hint of socialism in it, the U.S. has one socialized system of healthcare, the veterans healthcare system. So it's important also to distinguish between socialized medicine, where the government owns and runs the healthcare system, and universal healthcare, which is simply a system that guarantees healthcare coverage to everyone. Germany, Singapore, Canada, actually pretty much every developed nation in the world, except for us, has either socialized medicine or universal healthcare. And so this means that people don't have to worry about the cost of healthcare. If they are sick, they just get the services that they need. And this is particularly true when it comes to childbirth, which is amazing. I mean, in this country, you get the Family Medical Leave Act. You get 6 weeks unpaid. 12 weeks unpaid, meaning they will keep your job, you won't get fired for having a baby, but you got to be back within 3 months. Versus in somewhere like Great Britain, you can get 6 months off paid with an option to take a full year off, but with reduced pay for the additional 6 months. And that's pretty much the standard in Europe. At least 6 months paid to take care of your child after you've given birth. So that's very different, right, than in the United States. And so here it becomes a problem where if you don't have the medical coverage that you need, you just don't get the care that you need. Versus over in a lot of these other countries, the care you receive is based on what you need, and you pay what you can in a tax system that's based on how much you make yearly. So they take a little bit more out of your taxes, but that means that you then don't have to pay for healthcare at all, and actually don't have to pay for education, like college and other things like that too. Okay, moving on to the theoretical perspectives on health. Functionalism is looking at health and vitality being part of the stability of society, so they see sickness as a sanctioned form of deviance. So Talcott Parsons came up with this concept of the sick role. These are the patterns or expectations that define appropriate behavior for the sick and for those who take care of them. So meaning, a sick person has a role with both rights and responsibilities. To start with, they haven't chosen to be sick, so they shouldn't be treated as responsible for their condition. The sick person also has the right of being exempt from normal social roles, meaning you don't have to go to work, you don't have to go to class because you're sick. The exemption from normal stuff, though, is temporary, and it's relative to the severity of your illness. Also, if you don't take care of yourself, there's a problem with that too. The exemption also requires legitimation by a physician. That means a doctor has to say that you're sick. You can be sick, you can feel sick, but unless a doctor says it, it isn't really legitimized. So the responsibility of the sick person is twofold. They have to try and get well and seek technically competent help from a physician. And if the person continues to be sick, they may be stigmatized. So Talcott Parsons argues that since the sick are unable to fulfill their normal societal roles, their sickness ends up weakening society. Therefore, it's sometimes necessary for various forms of social control to bring the behavior of a sick person back in line with normal expectations. In this model of health, doctors serve as gatekeepers, deciding who's healthy and who's sick, a relationship in which the doctor has all the power. But is it appropriate for doctors to have so much power on deciding who's sick and who's not? What about people who are sick but are unwilling to leave their positions for any number of reasons? Meaning, they got to go to work because they have to pay their bills, right? They have personal obligations or lack of insurance or things like that. Okay, so conflict theory, those theorists are looking at issues in the healthcare system. As with most other social problems, they argue it's rooted in a capitalist society. So according to conflict theorists, capitalism and the pursuit of profit leads to the commodification of health, the changing of something not generally thought of as a commodity into something that can be bought and sold in a marketplace. In this view, people with money and power, the dominant group, are the ones who make the decisions about the healthcare system and how it will be run. They ensure that they will have healthcare coverage while simultaneously ensuring that subordinate groups stay subordinate through lack of access. This creates significant healthcare and health disparities between the dominant and the subordinate groups. Alongside the health disparities created by social class inequalities, there's a number of health disparities created by racism, sexism, ageism, and heterosexism. When health is a commodity, the poor are more likely to experience illness caused by poor diet, to live and work in unhealthy environments, and are less likely to challenge the system. In the U.S., a disproportionate number of racial minorities also have less economic power, so they also bear a great deal of the burden of poor health. It's not just the poor that suffer from this conflict between dominant and subordinate groups. For many years now, homosexual couples have been denied spousal benefits, either in the form of health insurance or in terms of medical responsibilities. And further adding to this issue, doctors hold a disproportionate amount of power in that doctor-patient relationship, which provides them with extensive social and economic benefits. Okay, then turning to symbolic interactionism. According to these theorists, that health and illness are both socially constructed. As we discussed earlier in the chapter, interaction is focused on the specific meanings and causes that people attribute to illness. The term medicalization of deviance refers to the process that changes bad behavior into sick behavior. A related process is demedicalization, where sick behavior is normalized again. Medicalization and demedicalization affect who responds to the patient, how many people respond, and how they view the personal responsibility of the patient. An example of medicalization is illustrated by the history of how our society views alcohol and alcoholism. During the 19th century, people who drank too much were just considered bad, lazy people. They were called drunks, and it was not uncommon for them to be arrested and run out of town. They were not treated in a sympathetic way because it was thought that it was their own fault and that they could just stop drinking if they wanted to. During the later half of the 20th century, however, people who drank too much were increasingly defined as alcoholics, people who had a disease or genetic predisposition to addiction, who were not responsible for their drinking. With alcoholism defined as a disease and not a personal choice, alcoholics became viewed with compassion and understanding. Thus, badness is transformed into sickness. And there's many examples of the demedicalization as well. During the Civil War era, slaves that ran away from their owners were diagnosed with a mental disorder called drapetomania, which has since been reinterpreted as a completely appropriate response to being enslaved. Like, obviously, you're going to run away because it's horrible to be enslaved. But they considered it a disease at the time. In a similar way, a more recent example is homosexuality, which was labeled as a mental disorder until 1973 by the American Psychological Association. So while interactionism does acknowledge the subjective nature of diagnosis, it's important to remember who most benefits when a behavior is defined as illness. Pharmaceutical companies make billions of dollars treating illnesses such as fatigue, insomnia, and hyperactivity that may not really be illnesses in need of treatment, more so consequences of how we live our lives and the way in which, our institutions tell us we're supposed to behave and act. And so it might be less about illness and more about opportunities for companies to make money when it comes to the pharmaceutical industry. So that's a whole nother way in which, we can interpret these issues in health from the sociological perspective.